Good afternoon. My name is David Serino. I'm the CEO of Envera Health, and we're really happy to bring you to a webinar that we think you will get a tremendous amount of value out of. We're attempting to really take on an issue that's been going on in the healthcare industry for quite some time, and we're excited to have you join. Before we get started, I just wanted to go over a couple of participation options, and that is you're going to see on your screen a question and answer box, and anytime that you want throughout the presentation, feel free to submit a question, and I'll be making sure to moderate a question and answer period at the end of the session, so feel free to submit anytime that you like. You're also going to see a couple of what we call audience polling questions during today's webinar, and when we reach each poll slide, the question's automatically going to pop up on your screen, and the speaker is just going to give you a few seconds to select an answer from the options, so we learn a little bit more about you and maybe some of the issues that you want to have covered and that you're facing, and I'm thanking you in advance for your participation in those. And the last thing, just kind of housekeeping-wise, is that today's session is going to be recorded and will be available after the event. You can use the same link that you used to log into today's webinar if you want to access that recording in the future. Before I get started and introduce our panelists today, a little bit about kind of why we're here. More of half of the nation's hospitals are facing readmissions penalties today. And what we're finding that's a really kind of smooth and effective transition of care program is really what's key to keeping these numbers down, whether that be in the ED or emergency department setting or an inpatient setting. Just so you know a little bit more data on this, on average, the penalties last year were about 0.75% across over almost 2,600 hospitals out there. Now, of those 2,600, just under 50 of them received a maximum 3% penalty. So these numbers really start to add up, and hopefully you're going to get a lot of information on the Bon Secours Mercy Health program that they work on with Envera Health, on how we kind of approach the problem, and then a lot of the best practices around that as well. But before I jump in and introduce the panel, I want to go ahead and just do a quick poll and really just answer the question on what option best describes your current role so we can get a feel for the type of participants that we have today. All right, and I want to jump in. I want to introduce our panelists today. First one I want to introduce is Erica Bentley. Erica is the Vice President of Clinical Services for Population Health with Bon Secours Mercy Health. This includes everything from care management, transitions of care, care design, and post-acute networks. Erica is a registered nurse whose original clinical background was in emergency care home health, and her MBA focus was on healthcare provider consulting and advocacy. She's worked in Pop Health for almost 10 years with 2 national players before coming to Bon Secours Mercy in 2017. Erica is leading a strategy that will allocate different resources and tools to the right population based on their clinical and social needs. Outside of work, Erica's got quite a great job. She's a mom of 2 boys and spends a lot of time on sports field and Boy Scout outings. Last year, she was actually the camp nurse for over 900 Cub and Boy Scouts, so God bless you for your work on that. Second person I want to introduce is Ingrid Kaiser. Ingrid's a registered nurse with a passion for patient care and patient education. With over 30 years of healthcare experience in various settings, including care management, oncology, physical rehabilitation, and management. Empowering patients to make informed decisions and advocating for nursing and healthcare really drive Ingrid's professional agenda. Her favorite pastime at present is being a granny to the 2 most adorable grandchildren ever, and I got a chance to see those photos recently. And the third person I want to introduce is Jeff Gill. Jeff joined the Bon Secours Virginia Business Development Team back in 2011 and has since held positions in managed care, finance, and strategy divisions of Bon Secours Health System. In his previous role, he also supported the population health strategy and operations and guided the development of clinically integrated networks in each of the Bon Secours core markets. Currently, Jeff's the VP of Virtual Health and Consumer Center programs and leads all of the efforts across the Bon Secours Mercy system, in addition to the retail and consumer-focused programs as part of the clinical operations structure. Jeff didn't give me a fun fact on himself, but he's just an awesome guy, so I think you'll enjoy hearing from him as well. And to really let you learn a little bit more about Bon Secours Mercy Health, I want to turn it over to Jeff.
Thanks, David, and appreciate everybody joining this afternoon, and excited to walk through some of the efforts that we've made around transitions of care. Just wanted to do a bit of a background. So some of you may have heard of Bon Secours, you may have heard of Mercy Health, some may have heard of Bon Secours Mercy Health, but Bon Secours Mercy Health is a not-for-profit Catholic healthcare ministry that serves about 7 states in the eastern United States, as well as the country of Ireland. We are one of the 5 largest Catholic healthcare systems in the nation. Have well over 1,000 sites of care, 48 hospitals, and revenue of over $8 billion. One thing that we are very proud of is our mission and our community focus, and we contribute nearly $2 million a day in community benefits. So we're very excited to be speaking to you today. About 1 year ago, Bon Secours and Mercy Health combined to form Bon Secours Mercy Health to service the states that I mentioned previously. The program that we're going to be speaking about today is oriented around the legacy Bon Secours footprint, or as we refer to it now, the Atlantic Group, that mainly services markets in the Kentucky, Virginia, and South Carolina areas. So like I said, excited to be here. I'm going to pass it over to Erica Bentley, and we're going to walk through together some of the common challenges facing health systems, and hopefully move very quickly into some of the results and some of the detail around the program that we've developed with Envera Health. So, Erica.
Thanks, Jeff. Hi, everybody. I'm really glad to be here. And so I think on a clinical operations standpoint, what you're always facing is sort of not enough people to reach out to all of the patients. Some of the patients get too many outreaches and some don't get enough. And so how do you allocate your resources the right way? And that's where we really started to partner with Envera on that. I think from a positive standpoint, Bon Secours, our Atlantic Group, was really focused. We had great hospital leadership engagement around redesigning care. We did daily interdisciplinary rounds at all of our hospitals. Our inpatient case management team is a highly developed team, very progressive around what they're doing. And we did have a transition of care program design. So we had all of those things going for us. And yet you still face trying to clarify the roles and the workflows for the right levels of patients. I think when a patient is in-house, whether it's the ED or whether it's inpatient, you can easily identify the patients who are going to need the most help. And you can also identify the patients who seem pretty safe to go home. But that gray area in the middle in determining what is the right level of need, who needs a nurse to outreach to them versus maybe a lower level of resource or tool, and that gray area is continuing to grow. And so that's sort of the problem that I was looking at from a clinical operations standpoint that we needed to address with a different program. And Jeff, I think you can sort of share what we're focusing on the administration and payment side of these.
Yeah, thank you, Erica. So I think you see some of the points here, and I think these are key phrases that individuals kind of react to when they think about transitions of care. I think changing expectations is one thing that I wanted to speak to briefly, sort of in the role that I am right now. I think a lot of us hear the words, access, affordability, convenience, digital front door, consumerism, some of these changing items in terms of what patients and consumers are really expecting out of health systems. And I think, so we talk about the clinical needs of our patient, but we also talk about changing expectations from those consumers across our markets. And I think, one of the opportunities that health systems have is that kind of continuum of care that exists within many of our systems. And so we have the opportunity when patients have engaged with us to really capitalize on that recent experience and look to build that relationship with patients and not really interact with them in sort of the traditional fashion, which is more transactional and episodic. And, I don't think that gets us all the way to the point of starting to build loyalty with some of our patients, but I do think it's a step in the right direction. We also, focus around readmission penalties. I think a lot of times individuals think about readmissions in terms of the readmission reduction program related to CMS that often targets, some of the highest risk individuals out of the inpatient setting. But I think regardless of sort of the care model that we operate in, transitions of care can be an effective model of care from a financial perspective as well. So you think about the broader population as we move to more value-based and risk-based care models with our payers. The goal of those programs being to improve quality, improve the health of populations, as well as reduce costs within those populations. And so what better scenario in which to kind of educate patients around the appropriate utilization of higher cost sites of care than, immediately after an experience that they've had related to that. We also think about, many of us still operating in fee-for-service environments and how that, it's still very valuable in terms of connecting with our patients, creating continuity between our different sites of care, whether it's from a hospital to a clinic setting or from a clinic setting into an outpatient setting, really starting to build that level of systemness within the organization, really starting to take advantage of some of what we can bring. So Erica mentioned, briefly, sort of the process and the focus that we had within Bon Secours Mercy Health. I think we often talk about conflicting priorities. I think, sometimes that's a strong word and sometimes has a negative connotation. I think it's really more about, competing priorities in terms of, community health and education. We obviously have a focus around the most vulnerable patients within our payer mix and looking at them and seeing what we can do to them to provide, the right level of care from a social perspective, financial navigation, transportation, education. We also have our hospital operations team, which is very much focused around efficiency and quality and monitoring length of stay and utilizing clinical resources to the top of their license. Then we have our medical group operations where we start to look at efficiency within the practice, provider schedules, how are we growing new patients, but also servicing our existing patients. And then we have more of our population health and care coordination teams where we think about, how do we leverage those finite resources, as Erica had mentioned. So really when we started to think about all of those things together, we decided that we really needed a program that could sort of address all of them at once. And so, as we move to some of the next slides here, I'll talk a bit more about that. So I think one of the things that we looked to eliminate or sort of address was, some form of duplicative communication with patients. How do we present a united front as a system and look to address kind of the wholeness of the patient needs versus maybe one or another needs kind of individually and not kind of making a connection around the patient as a whole and what they need and really trying to service them in a way that's the most efficient and effective for what they're doing. How do we make sure that the resources performing this outreach have the ability to close the loop on patients in terms of, if we need to schedule a follow-up appointment, if we need to connect them with a higher level of clinical resource, if we need to make a referral, if we need to give them information around community resources, we want to do that, and we want to be able to do that and close that loop versus having multiple communications back and forth. So hopefully that provides a bit of background on where we are as a system. I'm going to talk a bit more briefly about the program that we developed. But first, we wanted to sort of poll the audience to see if these are some of the same challenges that your organizations are facing. And then we'll move to sort of the program and how we've looked to address those. All right, so it looks like a heavy focus around readmission penalties, looking at finite resources and conflicting priorities. So I think we have a lot of consistency in sort of the way we're looking at this. So if we move to the next slide, I'm going to talk briefly about the program that we developed. So Bon Secours Mercy Health has or Bon Secours has relationships with Envera previously for other types of services, and we knew that they shared a similar vision around creating continuity and improving the experience of care for patients, especially in some of these more vulnerable scenarios such as transitions of care. So what we did was we developed a two-pronged outreach program. So the first piece being the outreach component, and the second piece being an escalation to a care management or care coordination intervention. And we'll talk a lot more about exactly how that process works and how that workflow is scheduled. But one of the other key things that we wanted to highlight was that also a lot of programs in this space, there's a technology component or a services component, and really what we wanted to do was we wanted to utilize technology in the best way possible to outreach to the most individuals in the most efficient way possible, to gather the correct data that we wanted to, but also have that personal touch from a services perspective. So that's why this program really appealed to us. So we got together a bunch of stakeholders from all the areas that I mentioned previously, and we rolled out this program across our inpatient and emergency care settings, establishing a data connection between the two systems, and the program has been very successful for us so far. And what we're going to do next, I'm going to pass it over to Erica, and she is going to dive in to some of the results that we've seen from the program, and then we'll continue into some of the details around the workflow. So thank you.
Great. So the first program I'll talk about is the emergency department program. And so we had this up and running at all of our Bon Secours hospitals in that Atlantic region. And this was a great one because most of us do not have the luxury of having a care manager full-time in our emergency department. I think it's one of the most common needs I hear when I speak to a lot of my peers. And so we did not really exclude any populations based on like payer or contract, I would say. So every ACO patient, everyone fell into this particular program except for some clinical exclusions. And because we didn't have the resources to outreach to all of these patients. So this was definitely filling a pretty large gap that we had there. We have great emergency care, but who manages that transition, that really special area when you're leaving our building and going into your own home? And so the first question this one asked them on the survey is, are you feeling better today? I mean, it's exactly what anyone would want to know. Are you feeling better today? And when patients answer that, it's considered interacting with the survey. There are follow-up questions, but that is the first trigger there. And what we wanted to look at was how many patients came back to the emergency department within 30 days. So there were 342,409 total ED discharges across these 10 facilities. You can see 80,000 of them interacted with the survey, and this resulted in 57,000 care plans. And if you just think of the magnitude compared to what your own staff can do in outreaching to patients, it's such a much broader reach of how many patients you can touch. And for those patients who actually did interact with the survey, 13.1% of them were less likely to revisit the emergency department. Overall, in 12 months, 1,527 fewer people came back to the emergency department within 30 days of their original visit. And regardless of payment strategies, reimbursement penalties, all of that, what I think about is if a patient comes back to an emergency department within 30 days, presumably for the same problem, we either didn't intervene enough with that medical problem, or maybe we didn't have the access or the availability for them to come back into their own PCP's office from us. And so this is where we either clarify their instructions, we provide a better intervention, or they redirect them back to our own providers, which is exactly what we need for them in that period, because we know a lot of the patients leave the emergency department and they're still quite confused on what they're supposed to do, or they don't necessarily know the right expectations that they should have. So that one question, are you feeling better today, really triggers a great cascade of transitions care for them. You want to flip over to the inpatient program? So the inpatient program was a little bit different in that we already have ambulatory care management and transitions of care that are outreaching to certain populations. So when you are inpatient in one of our Bon Secours hospitals, you have your provider, your hospitalist, your care manager, your nurse, your therapy, rehab therapy, are doing interdisciplinary rounds daily, talking about your progression of care. And that was no small feat to implement. And yet we still know we need to improve discharge planning. The majority of our patients leave our hospitals with an appointment scheduled with their provider within 7 days. And in some hospitals, we have a dedicated team that is their job to make sure these patients have an appointment scheduled in a timely manner and that they can actually attend, that they have transportation to get there. And so every patient is getting that service to some degree. And yet we have patients where we already have care transition nurses assigned to them. So it's great that we have a wealth of care transition nurses, but to the prior point, they are a finite resource and not everyone needs them. And so Envera worked with us to carve out who they would outreach to. And so that is that ever expanding gray space. And so we defined the populations that we knew were going to be on our list for outreach, and they decided to take over the rest of them. And that single question, that initial question that triggers the others and the interventions, are you feeling worse today? So a little bit different than the ED, but again, the main question you want to know about these patients. So in this program, and this was live in 2 of our markets for inpatient, multiple hospitals, but 2 cities, there were 41,254 total discharges. Of those, almost 14,000 interacted with the survey, so they answered that question, and that resulted in 5,900 care plans. And Ingrid is going to tell you a little more about what those care plans consist of and what type of interventions they perform. But overall, those who answered, that 13,000, almost 14,000, were 17.8% less likely to be readmitted. Now, you will see the readmission rates on there. When you look at those, remember they're reaching out to a slightly less risky patient population. So your most at-risk patients, my team is reaching out to, your team of nurses and care managers reach out to. Everyone who's a moderate risk and below is going to be outreached by this team. So Ingrid will explain a little bit about what they do, but it really did come in and fill a bit of a need that we had. We knew that we really had our hands around what was happening within our 4 walls, and that we knew that for distinct patient populations, we had care pathways, we had people, professional clinicians, and resources in place to take care of them. What we wanted to do was make sure that the rest of our population had that same level of safety net that's appropriate to their clinical risk. All right, and I will hand it back over to you.
All right, thank you, Erica. Let's take a walk through our patient journey together now. And this approach to the patient journey really is a collaborative process in being developed between Envera Health and Bon Secours. It really begins with the hospital staff letting the patients know that they will receive a follow-up call, which enables us to have the best possible reach rate. We can then provide timely, efficient, and scalable solutions addressing all of the eligible populations by leveraging our technology. Using IVR, we outreach to 100% of the eligible population. And as Erica just said, the eligible populations were really determined through discussions with Bon Secours. We can customize this by facility, diagnosis, patient class, age, and insurance, as well as for groups that they have in special handling, as she mentioned, such as navigation programs or care management. But we can touch 100% of all the other patients. So we ask 6 questions designed to help us determine the risk for readmission by measuring it against the factors that influence that, such as understanding of discharge instructions, compliance with the discharge plan, medication questions and compliance, and having a follow-up primary care appointment. For escalation, the patient can escalate for a negative response to any of the questions, either immediately by pressing a button, or they can request a callback later at a better time. On the intervention side, our clinical staff provides education on their condition, medication review, expected recovery process, signs and symptoms to watch for, review of discharge instructions and self-care instructions, and when to contact their physician for any changes. We educate on the need to have a follow-up appointment with their primary care doctor or specialist, and we assist them in making an appointment or finding an appropriate medical home for them. So if we move on to outreach and response, in order to truly be effective, a complex program like this requires continuity of care service and multiple areas of engagement so that the patients actually pick up the phone when we're calling. The Bon Secours team is driving awareness and increasing communication with each interaction. through things like patient-targeted handouts, which include colorful stickers on the discharge instructions, instructions posted on screens and monitors throughout the facilities, and even dot phrases that were included in the discharge instruction handouts. Envera Health is able to tailor the caller ID that goes out to that patient to the facility and to local area codes, which really helps to increase that patient's comfort in answering our call. We'll make maximum of 2 IVR and 2 agent attempt outreach calls, although it usually only takes an average of 1.8 per discharge to get a response. Critical really to the best possible capture rate for us is the facility staff confirming and updating that best possible contact number, and working with the ED staff in everyone asking that patient, what's your best number, updating it, and coming over to us through that automated feed really is what drives these excellent capture and reach rates that we have. If we move on then to our next slide, looking at emergency department discharges and talking a little bit about what we do on this basis. The questions we ask in the emergency department assessment are you feeling better today? Do you understand all of your discharge instructions? Do you understand how to take your medications and why you're taking them? Do you have a primary care doctor or specialist? Have you made your follow-up appointment? And finally, was our staff friendly and respectful during your visit? Through integration and really by logging directly into the health system's EMR, our clinicians can view the actual discharge instructions that patient was handed during their visit. We see the medication record, the history and physical, and any medical notes from their visits. This allows our clinicians to focus directly on the barriers the patient has and focus our workflows and interventions to mitigate these problems and to provide solutions. By reaching the patients at home at a time when they're not preoccupied with their illness event, we can talk with them when they're actually ready to hear and understand the information that's presented to them, and then really get them to participate with us in their plan of care for their recovery. One of the most common escalations that we see is for lack of follow-up appointment. So we provide solutions by connecting the patient to the providers after really explaining in detail the reasons why having a medical home and a doctor that understands all of their conditions is that important factor in maintaining wellness. We can provide assistance with resources too, such as transportation to the appointment and financial assistance when appropriate. On the next slide for the inpatient, our IVR questions, which is a voice response system that we use that the patient can react to each of the questions directly. The inpatient questions on the assessment are you feeling worse today? Do you need any help with your discharge instructions? Do you have any new medications or changes in medications? Do you have any new doctors or specialists? Do you need help with your follow-up appointments? And did you have any concerns with our staff not being friendly or respectful during your visit? In this setting, our most common escalation is for new medications or changes in medications. And this being one of the driving factors in revisits and readmissions, we really work hard at this by providing a comprehensive medication reconciliation, where we educate the patient, we ensure compliance with the medication regimen, with correct dosing and correct meds being taken, and in addition to education, we offer interventions to overcome financial barriers and access issues. Every day we see instances of patients that are continuing medications that were to be discontinued, taking both discontinued and new medications at the same time, or not filling their prescriptions for lack of understanding or for cost. We are able to outreach to PCP practices and to pharmacies to try to help with this, as well as provide information to the patients on financial resources and where medications can be obtained for free or for low copays. And we do find that it's often easier for a patient to talk to a nurse on the phone about their inability to afford a certain medication. It's not as threatening as talking face-to-face in the hospital with someone, I think. And sometimes this is as simple to resolve as our nurse talking with the PCP to switch a med. Sometimes it's not having told anyone that they can't read and they went home with printed out discharge instructions that they can't follow. And so having the nurse work with them to explain that, to translate what's written on there, and then to have the PCP coordinate, that really allows successful interventions to be implemented for these patients. We're able to identify unmet needs the patients have and provide immediate assistance, often relating to social determinants of health as well, and working collaboratively with Secours and their excellent network of community resources, as well as local and statewide resources. We provide information and solutions for things such as shelters, domestic violence resources, and food banks, for example. Envera clinicians can refer patients at risk for a return visit or who may need more intensive care management back to the health system quickly. So when we outreach to one of our patients within 24 to 48 hours, we really are catching them at the beginning of a potential escalation to become one of those higher risk patients that Erica mentioned. But we can refer them back to the health system quickly to be connected with the appropriate resources. We have workflows that are in place with established criteria that we've developed through interaction with Secours. And one of the other things I just wanted to mention as well is that one of the side benefits of a program like this is really the increase in health literacy that participants and patients come away with, as well as, of course, brand loyalty and the feeling that the healthcare system really cares. We do also talk with all of our patients about utilizing the proper level of health care going forward so that we continue to provide the best possible service to our patients as well as the health system. So by contacting the patients quickly after discharge, we not only mitigate all of the problems, the barriers, and provide the appropriate interventions, but we can also impact patient satisfaction scores by really listening and referring and resolving issues very quickly.
And, you know, Ingrid, this is one thing I feel like for us to get this feedback at the hospital for our teams or even for my care management teams, it really helps us continually improve to learn what we could have done better in the future so that we can actually improve our discharge planning and our discharge processes by way of that too.
Mm-hmm. I think it's been a very good collaborative process.
Yeah, and this is Jeff. I think to kind of add to that, Ingrid and Erica, I think one of the things when we started to talk about sort of previous programs, I think one of our opportunities was creating greater consistency in our reporting and understanding of the impact that we're having and the patients that we're reaching out to, and I think not only in the experience, from the experience perspective, but just overall in terms of the data and feedback that we get on the number of individuals that we're outreaching to, the number of individuals where we have inactive phone numbers, the number of individuals that, have challenges with discharge instructions or didn't understand, their medications. It's a very robust kind of data that we can start to utilize to customize certain programs around potentially specific populations. So I think that's definitely a key point in what we have right now is that, for the first time, we really have a level of consistency around the process, what we're doing, discrete information about the interaction with our patients in this space, not only the problems that they experience, but some of the challenges and how they're not able to address some of those problems, and then what we did to kind of help solve that issue for them. So we have a lot of great feedback anecdotally from the program with different stories, as you mentioned, Ingrid, but having that consistency of data around what we do and how we can prove out the value that we're adding to the health system and for our patients and community, I think is very, very, very effective. So thanks.
And just to build on that a little bit, you mentioned earlier having the appointment set up. Erica mentioned that a lot of your discharge patients have appointments in place. And we do see that when we log into the medical record and take a look at the discharge instructions. And I think at the time when the patients are being discharged, there is a lot of information that is being provided to them. And at times, they may forget that they had the appointment, not read back over those discharge instructions. We hear that they've lost them or they're not able to wade through all of them. So having that person touch base pretty quickly after discharge and remind them of the importance and say, well, you do have an appointment, or help them to facilitate getting a sooner appointment, really helps with decreasing the risk that they're going to be a return patient. I have another example. Just this past week, we had a patient that was having gastrointestinal issues. Her insurance required a referral from her PCP before seeing a specialist. The ED doctor had referred her to the specialist. When we contacted her, the patient said she called her PCP office, but she couldn't get in until 2 weeks later to try to get that referral from the PCP to see the GI doc. So our agent called the office and explained the situation, was able to get the patient in the next day for that PCP visit, which of course accelerated the amount of time that it took for her to get the referral to be able to see the specialist, get there in a timely fashion, and decrease the risk that she was going to come back to the ED for another visit. So it's sort of those, acting in real-time moments that I think are one of the huge benefits of this program as well.
Yep.
All right, thank you. Go ahead, Jeff.
I was just going to say, just to build on, I think I wanted to just take a step back and look at sort of the integration that we had on the front end, because I think that's really important when we think about the effectiveness of the program. So, obviously, working with a partner in Envera Health, there is some work to be done around integration and creating continuity and not creating confusion for patients. So I think we've mentioned it several times, but one of the really key elements that we did put in place was the access to our internal electronic health record, which we refer to as Connect Care. And that access, just having real-time visibility into information around the patient that Envera has, really just doesn't create sort of that dual, I guess I'll call it, kind of approaches sometimes that you may have with external care management teams. So just the access into Epic really provides a lot of value there from that perspective, so that we're not guessing at discharge instructions or guessing at medications. It's truly straight from the patient's chart within Epic when we're making those interventions and addressing those barriers. I think the other thing would be just sort of the upfront communication of this, and sort of the expectation that this is a continuation of your care with Bon Secours. So I think a lot of times these programs from an outreach perspective can really be seen as something different, and oftentimes that results in a real lack of engagement in the program. And so what we really did was we took a lot of time early on with our emergency departments as well as some of our inpatient teams to make sure that this program was socialized early and often, and also at the point of discharge from the facility, that this was a program that we were positioning because Bon Secours, is open and would like to, continue to engage with our patients once they leave our facilities. Our job's not done, but it's about also helping them re-enter the community and connect with the next care in their journey. So a lot of work done in that space, and as you can see, the engagement rates around the survey and responses is much higher than I've seen in a lot of typical programs, and a lot of that credit goes to Ingrid and her team, as well as our care coordination and care management teams at our facilities that did a lot of the work on the front end to make sure that this was a seamless process and a part of the Bon Secours continuum of care and not seen as something separate. So, but I'll pause there and pass it over to you, David.
Great. Thank you, guys. I really appreciate the time. Terrific presentation. We've gotten a lot of questions, so I'm going to kind of start moderating a Q&A now. And again, keep your questions coming in if you've got more. I've already got about 10 to go over. The first one is around kind of the number of care transitions you need to support this type of program and how the number was calculated. So was it a ratio based on number of patients? Like how many transitions of care nurses do you need to support this type of program?
So we took a look initially at volumes of the numbers of discharges. We get a live HL7 feed from the health system every night that gives us discharges. We take a look at the eligible patients, excuse me, that are left out of that discharge stream. And then by evaluating the amount of time needed to process the survey, the questions, and provide good education, we sort of grew the program up starting in one market, taking a look at all of the facilities in the Richmond area initially. And as we grew, we had increasing data to help us to try to be able to predict and proactively hire and have staff available for that. Excuse me.
Great. Thanks, Ingrid. Eric, I'm going to direct this one to you. Does the outreach by Envera after an inpatient admission count as a 24 to 48-hour follow-up for transitional care management?
It does not. So we do have a focus on those TCM visits and those billing codes. What we try to do, though, and I've seen both approaches in health systems, is one is they try to maximize as much TCM billing as they can, and I've seen other health systems that really try to focus on TCM visits for the right patients who truly need it. And so that is our approach, that we try to provide as many TCM visits with our providers to the patients who truly, from their clinical risk, can meet that requirement or meet that expectation for their care. So that we handle within our own internally. This is really to focus on a sort of a broader approach to that, as well as what the patient needs.
Okay, thank you. Eric, I'm going to throw another question at you. The question was, I was curious to know the timing of the survey completed by the hospital as part of the post-discharge management. So that could be the timing of, go ahead.
It might be the timing of our patient experience survey, Erica,
Patient
potentially.
satisfaction.
And, you know, I actually don't know off the top of my head when the patient experience survey goes out versus this one. I do know that we have a team that sort of looks at in terms of all the different outreaches that are going on and how do we manage those. There is some overlap that you can't avoid, but ultimately we try to look at those holistically.
Yeah, that's something, this is David, I'm going to jump in on this one. There's a lot of different ways to handle, you know, patient satisfaction and follow-up surveys. Kind of the traditional method could take, you know, as many as a couple to, you know, as long as 3 weeks many times. At Envera, we also have the ability kind of technologically to be able to send that actual satisfaction survey literally within any type of timing, whether that be, you know, moments after, so we can start actually getting real-time feedback onto a kind of a dashboard for a health system. So a lot of different ways that could actually be implemented. A question for the team. Why did we decide to ask the opposite questions for ED discharges versus inpatient? So more specifically, one of them we asked, are you feeling better? And the other one we asked, are you feeling worse?
I can answer that one. That was really a matter of the, technology that we had in place to be able to utilize the correct yes/no replies.
Okay. And then this is a really interesting question. I'm going to put this one out to Erica and Ingrid as soon as Ingrid has some water. Have you ever changed the survey questions after the first one to see if there's different results based on asking the fourth question second, or just a modification of the order of questions that you ask the patient?
No, we have not.
I think Ingrid can. Great. You know, I will say, having sat in a number of demos for different people that are in this space, there are always somewhat of a variation on the same. I suspect there is some evidence-based research behind this. I actually have a survey statistician in my family who has a doctorate in question design, and so I often pose these kind of questions to figure out the answers to this. But yeah, if you sit through enough vendors, they're very similar questions. I do not know if the order in any way changes it, but it does seem like a natural progression to me across the questions and how they're assigned.
And I think with the first question, we wanted to capture the attention of the patient and really capture are they better or not, and engage them in listening to the rest of the questions and being able to answer those.
Okay. Jeff, this is a question for you. How did you justify the transitions of care program to hospital management?
From a return on investment perspective, I'm guessing, in terms of the investment. Yeah, so I think it's a good question. So obviously, when you have a very high-risk patient population like what Erica's team supports, you have the readmission penalties and some of the other items there where you can build a value case around it. I think what we positioned this as more of a system-driven program in terms of engaging our medical group as well as our hospital management around the initiative. And so, really we positioned it as the community benefit around the program as well as the continuity within our network. So, creating connections back into our system, into our primary care, into our specialty, really is the big kind of driver of what we looked at as related to this. So, a lot of we have a lot of patients that were coming to us from an emergency room perspective or an inpatient perspective that did not have established relationships with our medical group, that often bounced into other systems, for follow-up care, and then ultimately, got the rest of their care within that system as well. So I think the main thing that we positioned around this was the continuity within our network and the value of that from both when we start to think about value-based environment, creating the continuity there within the network, but also from a fee-for-service perspective when we start to think about, how do we better build relationships with patients. So I think it's a first step in a program that we look at where we look to leverage technology, leverage services to reach a broader group of patients that we know have a need and that we know are looking for a different type of experience from a health system, and that they might value this type of coordination or navigation type service. And so there's a lot of opportunities to sort of refine this from a customization perspective with different populations. Maybe we would limit some of the clinical interactions for certain groups or get more specific around the mode of communication with other individuals. But it's all a part of a journey as a health system to become more patient-centered, consumer-centered in terms of the way we're interacting with them. So it was really kind of an initial pass there. And then also as we partner with Envera and really leverage the technology, leverage the right level of resource to be scheduling follow-up appointments, to be educating on different things. The program overall was one that was much more cost efficient than maybe investing in, a substantial group of clinical resources to manage this population. So hopefully that.
All right.
And, I would agree there because part of it too is, we've made the investment in the care management resources for those patients that are higher need. And so this is part of that complementary, other services that we can offer. But to add on to Jeff's point too, to hospital leadership, the real people always want to try to do these things in-house and they feel like it's more personal. And yet when you do that, if you are a nursing or care management leader, you know that those staff always get pulled to do other duties if there's a shortage in staffing, if there's something else that needs done. And this allows you to put a more scaled investment on people that you will be known to be dedicated to do that work.
Right. That's actually, there's another interesting question here that I'm going to pose to Ingrid. So what type of staff does Envera have in terms of like educational background, skills, and clinical that maybe differ from, again, what Erica's saying which is, I got to have all these people really, really focused. Is there a difference in the skill set and educational background that Envera does to support the Transitions of Care program at Bon Secours Mercy?
So all of our clinical staff, our nurses, have a wide variety of experiences, but heavy focus on emergency and critical care and intensive care. To be able to take care of a patient in the hospital setting, you have to be very confident in your assessment skills. To be able, when you're looking at the patient, touching them, and able to take their vital signs and everything, to be able to do that on the telephone takes really an extraordinarily skilled clinician with a lot of experience to be able to interpret not what you're seeing, but only what you're hearing, and be able to come out with a good assessment of that patient's deficits and needs for education, or to be referred back into the system, or even to be sent back to the emergency department. One of our nurses, for instance, was the leader for the National Poison Control Hotline in the past, and we have other clinicians that have equally as impressive experiences, as I said, in a wide variety of different nursing fields that allows them to handle any question. Any escalation that comes from a patient we never know what's going to come next. It could be somebody suffering from chest pain. It could be a new mom discharged that has a question. It could be a pediatric case. So they really have to have a significant number of years of experience and the confidence in their skills to be able to answer and handle all of those questions and provide good information. Again, partnering by logging into the EMR helps us be able to look at the discharge instructions, the physician notes from that visit, and helps the nurse to get a sense of where that patient was at. We also, in our system, are able to see alerts. We can see if that patient has been contacted by us before, and in the EMR see how many times they've been in the ED, which again allows the nurse to draw some conclusions as to the patient's past history, the patient's possible future needs, or is that patient at risk of becoming a high-risk patient, and as we sometimes call them, a frequent flyer, in which case we are able to contact Secours and refer that patient for more intensive management with the specialists that Erica has in place that may be more disease-specific or be able to handle that patient for a longer time frame.
Thanks, Ingrid. Eric, I'm going to fire off a couple quick questions to you. You might not have these answers. It's certainly okay to say we can follow up on that. Are electronic email surveys sent to non-respondents from telephone outreach?
Our electronic email, so people who did not respond to this
don't respond
outreach?
to the telephone outreach. Yeah. Do you provide it? Do you then try another channel to get a hold of that patient?
We do not. No.
Okay. The
That's
other
where
question
we would
was
hope
on.
that our. Go ahead.
Go ahead.
I was going to say that's where we hope that our natural process of having appointments scheduled for these patients in the normal provider office outreach is going to catch those patients anyway.
Okay. And then, Erica, the questions around, are family caregivers identified or included at any point? So instead of just the patient, what about the caregivers?
Yeah, so all of our programs, we try to be attentive to the family or the caregivers for them because they are so important. It's actually part of why we redesigned how we schedule appointments for patients before they leave the hospital, because if you don't know who's going to take them, you're not really scheduling an appropriate appointment for them. So they are, and in our documentation on patients, it notes who is the primary decision maker or if the caregiver is highly involved in that patient's care. And of course, it doesn't require that the patient answer the phone and complete that. And of course, when we talk outreach back to them, whether it's my team or Ingrid's team, we'd want to note who we were talking to. Also, that they are documented, that they are allowed to discuss the patient's care with them. But yes, as a system, and I think as a faith-based organization, we wrap around the patient and the caregiver a lot in our programs.
Great, thank you. And then Erica, this one you might not know, but it came in, so I want to make sure we cover it. How many veterans are you seeing and engaging with in this program? Any clue, like percentage-wise, maybe?
I definitely do not know. Are we talking about military veterans?
I'm reading the question for you, so I'm assuming that's the case.
Okay. Okay, I don't know. That would actually be very interesting. I'm always sort of interested in the makeup and demographics of our populations, for sure.
Yeah, for the person that asked the question, again, we're going to publish the Envera website where you can go to contact us, and anything that you say, hey, I'm the one who asked that question, we'll make sure we follow up and get any response, but you have to reach out to us so we know who to get back to. And then, Erica, there's a couple other questions that are really interesting. One of them is, how do you isolate the high-risk population? Is it based on admissions, on comorbidities? Because you kind of talked about the separation of those. How do you go about doing that?
Right. So we use our risk stratification tool. And so we have a risk stratification tool that is built into Epic. Now, there's the Epic cognitive computing model, and then there are other ones that can be used in Epic. So you may be familiar with one of them. And we use that to identify, we set certain thresholds where we know we tend to see patients who tend to deteriorate and break down. It involves the Carlson score. It involves other utilization metrics and demographics about the patients. One thing I'm very interested in pulling in now is functional and cognitive limitations, because you do see it, those patients compared to their typical other patients with chronic conditions tend to have a lot more complications. And I think, a discussion for another time is the sheer number of risk stratification tools that are out there right now, but we do use one that's built into Epic at this time.
Okay. And then I'm going to switch gears a little bit. I think this is a great question. First of all, the person said, excellent program and presentation. Now, where do you go from here? So, Jeff, I'm going to say to you, the question is, what are your next aspirational goals regarding transitions of care?
All right, I'll definitely ask Erica to comment here as well. But I think a lot of the questions, hit on points that I think we have opportunities to continue to refine the program. So from my perspective, it's really starting to take the data that we have now around the specific populations, around the payer segments, around the age groupings, around the payer mix kind of questions, looking at segmenting by veteran status, some of those other things that you mentioned, and really, again, getting more specific with the program, right? So we did sort of one layer of segmentation in terms of we're creating risk stratification for super high risk patients that we have out there, and Erica's team has a very robust engagement program around those patients. And then we now use the Envera program at the Secours facilities to reach out to sort of a second grouping of patients. So I really think it's looking at the data and getting more specific around this is really what patients need, this is what they're responding to, and customizing our programs in that way. And then again, to the return on investment question, I think the more customized you get in that, the less, inefficiencies you have in the process, and the more you can really meet some of the needs and produce a specific kind of deliverable around each one of the populations. So whether that's clinical revisit rates, whether that's readmissions on a higher risk population, or whether it's truly about getting the patient in within a period of time, how many appointments are we scheduling, how many community referrals are we making to different areas. So I think that's absolutely a piece of it. And then I think overall it's making sure that this program continues to be a part of what we're doing as a general care transformation strategy, as well as a consumer engagement and access strategy. So making sure that our interactions that we're making with patients from the acute setting are connected to what we're doing from an access setting within our medical group, and then also potentially starting to look at how do we utilize other types of programs like this, likely lower touch, likely less potentially clinical in nature. And, obviously I'm more the virtual health side. I think Erica can talk more about where we go from a clinical perspective, but, how do we begin to create continuity from our other sites of care would be something that I would start to think about. It might not have to be a, super invasive kind of touch, but maybe it's just a thanks, or maybe it's a, what do you need next kind of thing from our virtual video visit, or something along those lines. Or it's it's beginning to build out, the process around creating connectivity between our urgent care centers and our provider network, and our urgent care centers and our hospitals, and those types of things. So I think it's expanding to look at new care settings. It's also looking at customization. And Erica, I don't know if you had anything to add there, but I think we're at time.
Yeah,
We are
I just
at
want to
time.
jump
I'll
in
just
real
leave
fast.
one sentence. Oh, we are at time.
Go ahead,
I'll just
Erica.
leave one sentence, and that is, how do we take what we learned and use that to back into what we're already doing before the patient leaves the hospital and improve that? And I think that's my main focus for next steps.
Great. And I'm going to close this up with just a couple of just real quick closing comments. Thank you for joining us. You can see the Envera Health website address. Please contact us. We didn't get to all of the questions. There were some questions on documenting in Epic and Envera. We are our backbone by an entire CRM that gives us a 360-degree view of the patient. There's some questions about the cost of Envera. We have different types of models that we work with, not only on clinical types of transitions, but other all types of general information and scheduling. So we take millions of calls a year, as well as do different technology outbound things. So please feel free to contact us on there. And if you were part of the webinar, please identify yourself so we can make sure that we can actually answer any questions that you have. Other than that, have a great rest of your day.